Welcome back for the final session, a really exciting session. My name is Matt Hickman. I'm a professor of public health at the University of Bristol, but also here in NDARC at UNSW. And we've got two really great talks, plus we've got Michael as well, who tells me that he's a very fantastic human being. I should emphasize that, and I do willingly. So first, which is really brilliant, we've got Steve Shoptaw from UCLA, at the moment from UCLA, so things are happening very quickly in the US. And he's the co-director of the Big Southwest node of NIDA's clinical trials network. And if any of us, if you were in this previous session on methamphetamine treatment, you'll have seen that he's an amazing collaborator with multiple groups here. So Steve is going to talk and hopefully answer Nadine's session about what's a clinically significant difference, but also talk about towards evidence-guided strategies for whole person treatment for methamphetamine use. Thanks very much.
Thanks, Matt. It's great to be here. I mean, first of all, Australia is the land of methamphetamine research, so I'm very grateful to be here. And I have been told before that I am academically promiscuous. So UCLA is a land-grant institution, and its various entities have developed official land acknowledgments to recognize the Gabrielino, Tongva, and the traditional land caretakers of Tova Angar, the Los Angeles Basin. UCLA acknowledges that its existence resulted from the displacement and disposition of native peoples and recognizes its moral responsibility to impacted communities. Currently, I'm banned from making this statement in any lecture or presentation on findings supported all or in part by federal dollars. As a US citizen, I protest. So these are my disclosures. I do a lot of research with medications, so I have companies that I work with. They provide medications. Today we're going to talk a little bit about some of this clinically significant stuff and think about this thing, about the impacts of frequent high-dose methamphetamine use on multiple body compartments, to describe how using less frequently corresponds with better forensic health and social outcomes for methamphetamine use disorder. At the end, you're going to be able to name 2 evidence-based medication strategies for treating methamphetamine use disorder, and you're going to be able to build a whole person, not just their substance use problem, treatment approaches that start with medications and add evidence-based behavioral treatments. So one of the things I want to start with is talking about the sort of weird thing that happens between high-dose methamphetamine use and low-dose methamphetamine use. Glenn Hansen's lab published a long time ago that showed that low-dose methamphetamine use can be therapeutic, not touching any of the neurons at all, but high doses actually have cytotoxic effects, not necessarily in killing cells, but in eliminating processes in brain, which is where memories are held. So that's sort of, we'll start there and then think about, well, methamphetamine, when you use it, it has effects and functions that shape treatment goals. When you take methamphetamine out of a person's behavioral repertoire, you leave a big hole. There's all these positive and negative things that happen physically and psychologically. You can see them. Even the bad things are good. You can see that methamphetamine is popular among gay men, starting at the top, going clockwise, shift workers, people working 2 jobs, motorcycle gangs, women who want to lose weight, rural folks, youth, and now in Los Angeles and much of the US, methamphetamine is used at night among homeless people to be able to stay awake and protect themselves through the night. Here's what a weekend warrior looks like. The red bolts are the doses. It's a 9 to 11 hour half-life, so you start using Thursday night. Friday night, you might use some erectile dysfunction drugs to maintain an erection if you're a man. On Saturday night, you start using some weed on Sunday and a benzo, and then you slide into work on Monday or Tuesday. You might do this once or twice a month. Here's what a shift worker dose looks like. It's like almost twice a day during the week, and sometimes once or twice on the weekends. Here's what the blue moon, once in a blue moon kind of thing. It happens every so often. You can see it's just not that much. But if you start to think about the monthly cumulative exposure to brain and other compartments, what are we measuring here? Joe Friedman and Chelsea Shover published these data. They're not published, it's a preprint, showing that in methamphetamine tablets collected during drug checking at a syringe exchange program in Los Angeles of 120 people or so, you can see the mean dose of methamphetamine is about a gram a day. The potency of methamphetamine widely varies, but it averages around 80% potent. And if you look at the amphetamine equivalents to that, it's 1.5 grams of amphetamine that corresponds to that daily 1 gram dose. So if you total up by month, the amount of methamphetamine exposure that happens in brain, you can see here 10 grams, 53 grams in a month for shift workers, which corresponds to 85 grams of amphetamine equivalent. We're talking about, that's where a lot of these problems happen in brain and in other compartments as well. We see in US that stimulant use over time is concentrating, and as that happens, we start to see more and more comorbidities, including stimulant-related heart failure in the National Acute Heart Failure inpatient sample, and you can see in the red line that the stimulant, the numbers and the rates are going up through time, and this is, you can't see that from the back, but that's 2008 to 2017. But you can see the upward trend. Here we've done some follow-up, 20-year follow-up of people who were in our early contingency management trials looking at the mortality rate of people who have been in treatment for methamphetamine use disorder. And what we see is that there's a lot of folks who are dying, but it's not as important that you have HIV. That's not what kills you if you're a 20-year follow-up of methamphetamine use disorder. It's whether you smoke cigarettes. And in fact, you see that a 3 to 4 time mortality rate of men who use methamphetamine 20 years down the line if they continue to smoke. Philip Coffin, he published a paper just last week showing of people who were in San Francisco following overdose deaths of people who died from fentanyl and stimulants, and from stimulants. And what he was able to show that in that 12-year period in San Francisco that he published last week, that people who died with fentanyl overdose and fentanyl and stimulant overdose were younger and had simpler cases compared to people who were stimulant dependent only at the overdose. Those folks were older, they had more comorbidities, and he raises the point, Shane Dark, I don't know if you're in the room, but he raises the point about how that stimulant overdose is different than opioid overdose, plus or minus stimulants, and that involves both age and also much more fragile health. Garen here, one of you guys here, actually published this data showing that among youth, you can see that less use of methamphetamine actually corresponds with better health outcomes, particularly in inhibitory control. And in US, one of the things, this is an area where I'm focusing on, and that's pulmonary arterial hypertension. So as well, when you begin to concentrate the exposure of methamphetamine across the population through time, you not only see increases in myocardial infarctions and heart disease, but you also see the development of pulmonary arterial hypertension. Pulmonary arterial hypertension is a rare but deadly two-hit disease, meaning you have to have a sensitivity to why you're getting this disease, and then there has to be a second hit. In this case, it would be methamphetamine or HIV, and that leads you to having the disease of pulmonary arterial hypertension. We had a meeting about this last December at NIDA and NIG, the National Heart and Blood Lung Institute, and we were very excited. We were on our way to exploring this more closely to find precursors to people who are using methamphetamine who might be sensitive to developing PAH, because once you have it, you're just going to die. So, and unfortunately, that got unplugged, as well as many other things has gotten unplugged in US. Here's the data that show the concentration of the dosing of methamphetamine and methamphetamine-associated pulmonary hypertension, with the highest prevalence in the West, next to the Midwest, the South, then the Midwest, and then the Northeast. Chris Jones published these data in publicly funded treatment episodes in the US and saw that the highest prevalence of treatment for methamphetamine use disorder happens in the West in publicly treated settings, then the Midwest and the South and the Northeast. So it actually goes that way. So these data are correlational, but show on a population level that you are going to start to see PAH. And one of the things I've talked with some of the folks about here is to begin talking with your cardiology or your pulmonology clinic and begin finding out what's happening here in Australia, where you have one of the longest exposures of high-dose methamphetamine anywhere on the planet. I would encourage you to start bringing the pulmonologist into the discussion to think about whole person strategies as well as cardiology. And of course, there's infectious disease, and we see here that in cohort studies in the US, we see that methamphetamine use among gay men is an attributable fraction of 16% in one cohort and 33% for incident HIV infection in the US. By contrast, social networks reduce HIV incidence in MSM. These are black MSM, about 1,600 black MSM followed for a year in US. And you can see, you can't see here, but the idea here is that if you have non-drug using social supports, that there's an additive effect. The more social members in the social network who are non-drug related, the more protective you are about HIV infection. And here's data we published about 2 years ago, showing that among methamphetamine use, people who use methamphetamine, social and health outcomes are reduced in dose-dependent fashion based upon the frequency at which you use methamphetamine. So on this chart that you can't see, the circles are none, the squares are monthly or less, and the diamonds are weekly and more. And you can see that for unemployment, for housing instability, intimate partner violence, new anal intercourse partner, concurrent sexual partners exchange sex, positive STD tests, and detectable viral load among people who are living with HIV, renal condition, neurological condition, and psychological condition. There's a statistically significant difference in difference across weekly or more to monthly or less, and monthly or less to none. So one of the questions about what is a clinically relevant outcome. A clinically relevant outcome that you can see differences here is reducing the frequency of methamphetamine use. So, just one of the questions. And we talked about this in one of the other sessions. This is important. If you haven't downloaded this and have it on your computer, you need to do this. This is the clinical practice guideline in the management of stimulant use disorder. It's published by ASAM and the AAAP, and it's free and you can download it. And actually, this manual has the references for the rest of the talk that I'm giving today. So in terms of the status of medication development for stimulant use disorder, there's no approved medications. But there's a small suite of medications that have strong evidence of efficacy. And one of the discussions we've been having here this week is how do we take some of these repurposed medications where we see a signal for efficacy and get them through an approval process. So that's a discussion that should continue after this meeting because these are generics. There's not going to be a pharmaceutical company that's going to line up. We need to find some places that are interested in doing social good, not just making capital. The strongest evidence in the guideline for methamphetamine use, and you've heard some of this already, the broadly effective medication for methamphetamine use disorder, this is the trial that Madhukar Trivedi and I did. It's a very complicated design, and I'm just going to walk you through a little bit of this. It had 2 stages, the first 6 weeks and the second 6 weeks. In the first 6 weeks, you were randomized 1-3 active to placebo, so there were 300 patients in the placebo group and 100 patients in the active group. And the outcome here was 3 or 4 negative urine samples for methamphetamine use collected on a twice-weekly basis in the last 2 weeks of the weeks 5 and 6. And you can see here a significant difference between active and placebo. And then for these groups, their contribution to the analysis ended. This is called the sequential parallel comparison design trial. And then what would happen here is if you were in the placebo group and you weren't responding, you were randomized 1-to-1 to receive placebo, or you would go into the active condition here. Together, you can see in both cases, this is what's really cool. After 30 years, here's a medication effect. And again, here's a medication effect. And when you put this together, you actually get an 11% difference between a reduction in methamphetamine use using this combination. The number needed to treat, always a good idea to know, is 9. And I'm going to come back to that in a second about why that's important. A junior professor with me actually said, what happens to the folks in the active condition weeks 7 to 12, because they're not in the original analysis. And you can see here, here's weeks 1 to 6 in the active condition, and then weeks 7 to 12, they continue to increase with the percentage of negative urine tests about 30% by the end of week 12. That's a significant clinical difference. We had to sell that to the New England Journal, but they bought it. So how does this work? We don't know. I will tell you, naltrexone by itself doesn't work, bupropion by itself doesn't work, but you bring them together and something happens in the body. Actually, I'm working with a group of medicinal chemists to kind of understand what happens at this combination, and maybe there's an optimal dose that we don't know about. We were using repurposed medications, but something happens when you bring the body into the body, naltrexone and bupropion, something metabolically happens that's magic. It helps you lose weight, and it helps you stop using methamphetamine. So I'm not sure why. Here is the other data for mirtazapine. So Dr. Rebecca McKeaton will be presenting on this soon on the outcomes. But of the big trial that's confirming whether this works or not, this is Grant Colfax's trial, Philip Coffin's trial, and you can see here about an 15 to 18% reduction of methamphetamine positive urine samples collected in the first trial in 2011 and replicated here in the second trial. And why is this important? Because the hardest thing to do in science is the same thing twice. In analyzing these data, you can see that the black diamond is different here for urine, meaning the mirtazapine is reducing methamphetamine detection in urine, but it's not doing anything for this is retention or depression, so it's not working in those ways. So who knows what's going on there? We'll be finding it out, and I'm guessing that Rebecca's trial will actually give us some chances to dismantle some of the mechanisms by why things are happening. It could be restoration of sleep architecture, but the definite thing is it's not doing anything for depression. So there are also this is also covered in the clinical practice guideline, but I think it's important, and that there are some medications with weaker signals that aren't being pursued much. One is psychostimulants, and we had some presentations today about new trials coming out using higher doses of psychostimulants and seeing whether they work for folks with methamphetamine use disorder, not only to reduce methamphetamine use, but also to help with methamphetamine withdrawal. One of the problems with psychostimulant studies is that we've not been able to push dose very high. If you have a 1 gram a day dose on average coming in, to go to 70 milligrams of Listex or to 110 milligrams of D-amphetamine is really a place where our participants look at us like we're kind of nuts. So there's other medications that have been trialed. Some of them have some effects, some of them don't have other effects. And it's really hard to figure out what to do with them. And the Krista Seifeld's systematic review is helpful, as well as the practice guideline. But I also want to point out that it's really important to remember that a significant side effect of regular methamphetamine high-dose use is methamphetamine psychosis. And in that case, you have antipsychotics that are effective for reducing the the psychotic presentation. This is really important to remember, because when I talk in other rooms about using the combination of extended release naltrexone and high-dose bupropion or mirtazapine, a doctor will come up to me and he'll say, well, I had this guy, he was psychotic as all hell, and I gave him mirtazapine and nothing happened. So it sort of is like that's not the point. If you have a person who's in florid psychosis, you would treat the person with an antipsychotic, and then you might institute mirtazapine down the road, but you wouldn't expect that mirtazapine would reduce psychotic presentation. So I tell you this story not because it's kind of silly, but it's because as we develop these medications, we have an obligation to bring our field along. The folks who are trialing things will trial our recommendations, and they're going to have differing outcomes. So we need to have a conversation with the clinicians, with the GPs, with the folks in the emergency departments about how you work with these. I've been doing this in California, and we'll work with the emergency department folks to say, use your antipsychotic, get the agitation cleared up, and then maybe bring in the medication that might work. And just as a PS, antipsychotics have no effect as a regular treatment for methamphetamine use disorder. There's not one, and there's been a multiplicity of antipsychotics that have been evaluated, and they just don't do anything, and in some cases can make things worse. In terms of withdrawal, we don't have much going on that we can say that would work. Again, here, ameniptine, which is a pretty strong stimulant, actually shows an effect in reducing methamphetamine withdrawal. And Liam Atchison and the folks in Nadine Ezard's group are working on looking at using long-acting Lisdex and having a reducing dose from 250 milligrams to 0 to see what might happen. That will help in terms of the acute phase, but where we're not even looking yet is in this late protracted phase. And we have a problem with people who are in the longer periods of methamphetamine abstinence who are feeling the effects of protracted chronic withdrawal, who return to a single use of methamphetamine, the lights come on and off they go. And that defines negative reinforcement, which is actually one of the hardest behavioral patterns to extinguish. So if I were at the front end of my career, this would be a place I would be looking. You guys are already looking there, but I would also begin thinking about what to be doing out here, because that extended period where you have those negative reinforcement effects is something that I would be thinking is a really important place to look forward. Now, here's the science fiction part of my talk. This is Clear Scientific 1103. It's CS 1103. It's a meth antidote. And we're just getting ready to do the phase 2A trial in this. This is a small molecule that is actually designed to sit in blood, and it will find methamphetamine come along. It will make a complex. Has a very high binding potential for methamphetamine. The complex gets made, and then it's escorted to the kidneys and eliminated in urine without the methamphetamine being metabolized. So it can actually take, in non-human primates and dogs, it will take an 8 times lethal dose of methamphetamine and clear the blood of methamphetamine in under a half hour. So you have this amazing sort of new treatment that's on this horizon that will start in the emergency room. But one of the things that I've been having fun discussions with this week is once we have an indication for this, and it will happen, once we have the indication for this, we put this into patients' hands. So if somebody comes in and in that longer period of protracted withdrawal has a weekend where they fall off their methamphetamine goal, has a relapse, they could actually have their weekend, take this medication on Sunday, and pass a urine test on Monday. So this could actually revolutionize the addiction treatment field. So there goes all the shame, there goes all the self-attribution that I'm a piece of shit. This is all about being able to manage addiction like a regular chronic disease. This is our future, folks, and I actually get really excited about this part. But so we're going to the field very soon. Here it also shows that it has an effect in working with fentanyl. It has a very high binding potential for fentanyl as well, which is great for us. This is just the size of behavioral therapies for stimulant use disorder, and I put this here because we're talking about medications, but we need to be thinking whole persons. And you can see here that contingency management has the highest effect based on blue dots, treatment as usual, CBT, and then combinations. But we need to not be thinking about we're going to treat with a medication or we're going to treat with a behavior therapy. We need to be thinking integrated and begin thinking about models that bring the best of medications. If you're one of those 8 that respond to mirtazapine or 9 that respond to the combination, then that's great. Then you don't have to work to help meet your methamphetamine use goal, which is fantastic. But if you're one of the ones that don't respond, you're going to need this plus something else. So this is kind of what I'm thinking. And for clinicians, we should not be thinking about, are you the right person for a medication? We start with the medication. We actually begin there and we treat as a population, not as a particular patient in front of us. Philip Coffin is also leading the field in terms of thinking about what to do with people with incomplete response. Did you listen to me when I said that people die of heart attacks and pulmonary arterial hypertension? How would you treat someone in the community that has a risk for heart disease? You would start them on a statin. That's what you would do. You would begin looking at blood pressure medications. That's what you would do. And you would pay attention to that. This is where whole person treatment starts, not just when you see your patient in front of you and he or she is asking for care for methamphetamine use, but then you say, let me get your blood pressure. Let's do some labs. Let's see what's happening. We need to see what's going on with your cholesterol and be able to protect whatever the cardiovasculature that still is there and maintain it. I think that's really brilliant, and there's no data on this. There are some data from HIV showing that bringing in a statin is health protecting. So I don't know that we need to do the trial that says, if we bring statins on active meth users, do we find a health benefit? Maybe we do, maybe we don't, I don't know. You can figure that out. But the other thing, smoking cessation, we need to think about that. And then Philip also does something. He has a chill pack, which is he sends people out who are having problems with meeting their methamphetamine use goal, who have transient psychotic states with their methamphetamine use, and he'll send them out with a tab or 2 of quetiapine. So this is just something to think about, and it helps people to bring treatment into their own hands. So after 25 years, there's some signals for efficacy. There's still no FDA-approved treatment. Mirtazapine effects in MSM are impressive. We're waiting for Dr. McKeaton to present her findings. I'm hoping it'll be a home run. Large trial for extended release naltrexone and high-dose bupropion over placebo for reducing methamphetamine use. Use it, folks. It does work. I've heard patients say thank you, so it's worth doing. There's a strong signal that negative consequences to methamphetamine use are reduced simply by using less frequently. Patients may come in and they may not understand that using less frequently is a clinically relevant goal. Behavioral therapies may boost medication effects. Antipsychotics and sedatives are effective for meth toxicity. Preventive medications may prevent disease burden and build health, which leads to this sort of graphic that a medication for methamphetamine use disorder is like the foundation of a house. It's not the walls, it's not the people who live in it, it's not the art on the walls, but it is the place where you start to build. So we need to rethink our perspectives in terms of treating methamphetamine use disorder. And we currently have evidence to consider using medications as a foundation of treatment. The first thing they walk in the door, everybody gets, if they're not having a problem with the particular medication, they start medication as part of the treatment. So here's my child graphic of where we need to go. So here we are, folks. We're in here. We do all this noise about all this stuff in here, but our patients also have infectious diseases, and they also have medical and physical health diseases and disorders. And how do you get from here to here or here to here? The catwalks are not here. This is the next 10 years of work in this field, is to stop with this addiction medicine stuff that is only about addiction medicine and begin doing intersectional work with our colleagues in infectious diseases, with our colleagues in cardiovascular diseases, in pulmonary, in dental, and not to mention psychiatric, because our patients don't have the wherewithal to get from here to here to here on a regular basis. So that's where I'll leave you today. Thank you very much.
Superb. Any questions? There are mics roving. There's up there, if you could just say a little word of who you are. Thank you.
Thanks, Stephen. Great talk. Jonathan Brett, St. Vincent's Hospital. You mentioned the chill packs. We see, like, clinically, so many people with meth psychosis. Has that been evaluated?
I'm sorry, I lost that last one.
The chill packs.
Yeah.
Has that been evaluated? Or?
Have they been what? Evaluated. Not in a clinically randomized trial. I know Philip does this as part of his head of the San Francisco Public Health Department, so he puts it into a program. Let's find out from him. I'll find out whether he has any evaluation reports on it, but I know it's not going to be a randomized trial.
Super. Any? Yep.
Sorry. Ben, harm reduction at Redfern. Just curious, any trials on disoxin in the States?
In the what?
Disoxin?
Disoxin. I don't know what that is.
For ADHD.
Oh, you mean mixed amphetamine salts?
Yeah.
Yeah. So there is a trial that Frances Levin has done. She's done a couple of these trials with mixed amphetamine salts for people with cocaine use disorder and ADHD. And what she sees is a dose response in terms of producing cocaine negative urine with 80 milligrams of mixed amphetamine salts better than 60, and both of those better than placebo in terms of helping people with respond to cocaine use disorder.
Brilliant. Great. Thank you very much. So Steve will be hanging around later as well, so you can get him at the reception after. So our next talk is from Ryan Courtney, who's from NDARC, and is an associate professor with UNSW and a National Heart Foundation future leader. And is a behavioral scientist, done some fantastic trials around tobacco and works with lots of my colleagues in England. And more importantly, for those who last year, he was tantalizing about the results, and now finally we get the results of a trial. So Steve, Ryan, do you want to come up? He's going to talk about vaporized nicotine products for smoking cessation among people experiencing social disadvantage, a randomized clinical trial with results this time. Thanks.
All right. Thank you so much for the introduction, Matt. Much appreciated. In terms of conflicts of interest, none to declare, and any other conflicts are mentioned in the paper. So this project was funded by National Health and Medical Research Council, and it was an HMRC project grant. It had a long evolution. Obviously, we had a bit of COVID, and even when we started the trial, we had to relabel some of the meds with change in TGA regulations along the way. But I'm very happy to present today. It's been a long haul, and in particular, thank you for the contributors and authors that have stuck around for the long haul. So as you know, smoking in Australia, there's close to 2 million that are daily smokers, and around 8.3% of the population, a slightly higher rate of smoking in males. And despite our efforts over recent waves, we have seen reductions in overall smoking, but amongst those that are older, those 60 to 69 and 70 and older, we haven't found reductions in the last two National Drug Survey data sets, but what's been a common denominator across all those waves, and it doesn't matter which data set you look at in Australia, but in particular around the world as well, that we often find a high rate of smoking amongst those from disadvantaged areas in particular. So typically smoking rates can be up to 3 times higher than those in the general population. And we know that people from the lowest socioeconomic areas or populations, or those that are socially disadvantaged, unfortunately bear the brunt of the health burden associated with tobacco use. So we do need more effective interventions. So there's been many calls globally, not just by NHMRC and New South Wales Health here, but there has been lots of calls for more research in terms of what role does vaping have in particular for smoking cessation. So that was one of the key drivers, obviously, of why this research was done. So we take a moment to pause. So this is what you call a Cochrane Living Review. So it grabs all of the studies we know that are randomised control trials. So comparing 2 active treatments in this case, one's vaping products and the other's nicotine replacement therapy. So the latest evidence suggests that vaping is a more effective aid with high certainty evidence. But I think the important thing to note here is when this, even in this review now still that's published, it was always confined to general population. So we didn't know exactly what role vaping products might have in a socially disadvantaged, or what the Cochrane group calls a priority population. So the novelty in this study in particular is to look what effect they could have within a socially disadvantaged population in terms of the outcomes of the clinical trial. So in terms of policy and context, so you have to, when we did recruit for this trial, you have to go back a few years to try and remember, but use was initially required under an access scheme called the Special Access Scheme, and during the trial, classification of vaporised nicotine products shifted from prescription-only medicine and only available through doctor's prescription, with purchase, as you may remember, from an Australian pharmacy, or if you do remember also the personal importation scheme that was in place at that time. And there was no e-liquid flavour restrictions at this time point either. And when we started the trial and nearly all the way through it, the RACGP, the Royal Australian College of General Practitioners, and HMRC and all the leading state and territories, health bodies and leading public health bodies didn't authorise or endorse vaping for smoking cessation. But towards the end of the trial, the RACGP did recommend, and they still do now, vaping as a conditional endorsement for use amongst patients that have tried on other frontline treatments and failed. So what did we do? So we did a big trial. So we recruited over 1,045 participants that were randomised and analysed. We recruited within the Sydney and wider metropolitan area, so about 150 kilometres from our trial coordinating centre. We provided both groups with 8 weeks supply of free quit smoking products, and particularly for the inclusion criteria, participants had to be in receipt of a government pension allowance, which was a good proxy measure for social disadvantage. They had to be current daily smokers and interested in quitting. And we followed up participants for 7 months with a primary outcome of 6 months continuous biochemically verified smoking abstinence. So that was measured via what we call in the field Russell standard. So they had to be quit for 6 months and allows for 5 cigarettes in total in that whole period. And they had to also pass a CO breath test to be a treatment success. So in terms of the study flow, so we recruited through Facebook and Instagram. So participants would then put in their form fill online. It would come to our study inbox, and then members of our team would call and complete screening and consenting, and a study physician would review their file for enrolment and call those that may have had precautions and enrol them if they were eligible for the study. The baseline interviews and the follow-up interview was done by a contract research organisation separate from the study team, but we did the check-in calls during the study and the screening call, as I said earlier, and there was 2 check-in calls in the first months of treatment. And after the baseline interview, participants were randomised either to the vaping group or to the nicotine replacement therapy group, and 2 check-in calls happened thereafter in the first month, and then the final interview at 7 months. And for those that had met the primary outcome I said earlier, they would then completed a CO test, either online via a Bluetooth ICO CO monitor or a face-to-face test that we did generally at their homes. So this is the first vaping device we had in the trial. So this, at the time, probably wasn't obsolete, but probably is now. It used freebase nicotine e-liquid, and we provided tobacco, menthol and berry flavours. And it had 18 milligrams per mil in terms of nicotine strength. And the other device that we used was an alt vape with 40 milligrams per mil nicotine salts, and the flavours provided were tobacco, menthol and mango. And I think importantly here, if you think back to the Cochrane review that I introduced a little bit earlier, the novelty of this study was this is one of the largest trials that have evaluated nicotine salts. So nicotine salts in terms of delivery of e-liquids has been an advancement in particular because it allows for a higher dose of nicotine to be more palatable and enjoyable for the user. So whereas freebase liquids were a little bit were harsher in terms of their delivery. So, and also providing flavours is a point of difference that we did in this trial, and probably the high dose of nicotine strength as well, which was a limitation of some of the previous trials. So in terms of the packs, so for the nicotine vaping group, they got in pack 1 an alpha tank device and a pack of replacement coils, bottles of e-liquids in the 3 flavours, and they also got the alt pod device and a replacement battery, alt pre-filled pods alongside that in 3 flavours, and a wall adapter and charger. And for pack 2, the second 4-week supply of that total 8 weeks, they got a device and flavour preference, so they could choose between either the alt or alpha or both, and choose one flavour or all flavours if they wanted to for both. In terms of nicotine replacement therapy, so we provided nicotine gum or lozenge in 4 milligrams, and participants could change their preference in the second pack. So in terms of the comparator here, I know that we only provided single form NRT, but typically that's how, despite our efforts to always provide combination NRT, typically in the real world, only one form is used. And also, with both being relatively fast-acting NRTs as well, they were both oral comparators in terms of the mode of delivery. And in terms of behavioural support wrapped alongside those treatments, they were provided 5 weeks worth of text message support. So that's 112 messages in total. 93 were just general specific texts that both groups got, and 19 were treatment specific, depending on which group they were allocated. There was also a quit buddy called Lou that was a part of the program, and the frequency ranged from 2 to 5 texts per day, with more texts at the start and tapered off as less towards the end of the short program. And it included texts, emojis, web links, videos and GIFs as well. In terms of baseline characteristics, so there was as I said earlier, over 1,000 randomised first though, but predominantly female sample, 67%, which is quite often when you do recruit through social media, you do find that you get more females recruited. And the median cigarettes per day was 20 cigarettes, and importantly of our sample, 42% had reported either a diagnosis or treatment for a mental health disorder in the last 12 months. So, for the most important part, the primary abstinence outcome. So we found that 28% of those allocated in the vaping group had quit and met our primary outcome, versus just under 10% in the NRT group. So it was a 3-fold higher quit rate. The Bayesian posterior treatment effect was 18.7% in terms of the difference between the two groups, and the estimated posterior probability of superiority was over 99.9% with a uniform beta prior. And we also did a sensitivity analysis where we look at the data from the Cochrane review as well, and that also showed a clinically significant difference. And also for our per protocol analysis as well, that's when you consider those that had used the dose, plus the fact that a significant portion of people in the NRT group actually did start using vaping. So if you reduce them out of the sample there, what the effect is as well. So in terms of the primary abstinence outcome by subgroup, you can see there the effect was quite stable across all the different subgroups that we had. But in particular there, even for those that had self-reported a mental health disorder or either diagnosis or treatment, that it was 26% had quit and versus 9% in the NRT group there. In terms of secondary abstinence outcomes, so they were found to be effective and significant in the vaping group for all comparators. So that included just the self-report outcome, not worrying about the CO test, point prevalence at those time points where for the last 7 days we asked whether or not they've had a single puff at 7 months, as well as check-in calls as well. But there was no significant difference between groups for the number of cigarettes smoked or proportion that had reduced their level of smoking from baseline to 7 months. So I guess this is an important outcome of the study as well, which I think will help to guide health practitioners into the future in particular. So we did find, even though for those that had quit smoking, as you can see there, they'd met the primary outcome. Close to 6 in 10 were still using their allocated product at follow-up. So for some, some clinicians may see that as a win, and I think it is a win because they've stopped smoking. But I think more longer term, I think we need to be considerate about how we go about conversations with vaping, and potentially it may be a longer term maintenance, but how we support those that have smoked to use a vape and then to also transition to stop vaping longer term, I think is where the field needs to go. It doesn't need to be any more conversations about does vaping work for smoking cessation. I think now with this trial, plus others that I know that will go into the living review, high certainty evidence is the highest level of Cochrane evidence you can get. It doesn't get any higher than that. So I think, yes, as the field now needs to grapple now with how do we support those, and some people may not want to stop vaping, but the reality is some people will, and we need to be able to support them if they do wish to. And also, as you can see there is some issue as well amongst dual use for those that follow up that were using both cigarettes and vaping as well. In terms of adverse events, so we found they were less frequent in the vaping group overall compared to NRT, and there's a snapshot of some of the most frequent adverse events reported in the trial. And there was no difference in respiratory outcomes as measured by some of the respiratory measures that we used that were self-reported. So in terms of implications, I think we now know that vaping is more effective than NRT, even when we just use minimal behavioural support. So we just provided them with very basic and simple text message program for that short period. I think what we know now for the general population also applies to the social disadvantaged as well, which is a really important thing. And often when we do trials like this, we seldom find treatment effects within the group that we want to serve the most, that is in most need and affected. So it's a really positive finding in terms of the results for this trial. A few trials have evaluated multiple flavours and devices and nicotine pods. So our trial design doesn't allow us to answer that question about whether or not flavours do lead to more or higher quitting rates. So there probably needs to be some more work in that area in particular. I think one of the advantages of this trial in particular was probably the ability for us to provide a sufficient level of nicotine delivery to make sure people can quit smoking, where in previous studies often they hadn't had an ample dose of nicotine in terms of milligrams per mil. And also with the study design that we put forward too, we made an attempt within an RCT to partially replicate the routine setting with device choice and flavours as well. But as I said, continued use of vaping at long-term follow-up may be problematic, so something that we may need to look at on the horizon. In terms of limitations, so it was an open label trial and treatment assignment wasn't blinded. Whilst participants in the NRT group didn't get a wider choice of other NRT, we do know from the literature though that hasn't been found to improve quit rates in terms of trials that have been done. And also to consider, I'll let others in the audience think about this, but most public health bodies had cautioned against or discouraged use, whereas NRT did have unanimous endorsement when we did do this trial. The treatments too, in particular, they're not equal in terms of the way that they are supplied in the routine setting. And continued use data was confined to the allocated product. And as we know, CO testing only is a marker for 24 hours exposure. We were dealing with nicotine replacement products here, so cotinine couldn't be used, but anabazine could have been used, but it's a very, very costly marker to look for in terms of longer term exposure. And finally, in terms of acknowledgements, thank you as always to our federal government support for NDARC, our NHMRC project grant. The participants in our trial, very thankful. All our staff at the Trial Coordinating Centre, as a PI, I'm very proud of this, but the amount of work that you can get through in a day, every trial I do just makes me want to turn up to work more and more. So thanks for all the hard work you do. It's amazing. I don't know how you do it, but to be able to publish this work in such a prestigious journal as well, and to be able to talk about the findings today that I think can generally change practice is really important. And also thanks to the stakeholders, our study physician, and all the Data Safety Monitoring Board. And thanks everyone today for listening.
Absolutely fantastic. We've got time for a few questions. Yes, down there. Thank you.
Hi. Thanks for your presentation. My name's Amber. I'm working currently at the Public Health Unit in Sydney. So my question just was about the choice of NRT to compare the vapes to. And so my question is probably more regarding one of the issues I understand smokers or vapers have is that hand-to-mouth kind of habit that they have. So understanding that the choice of NRT was either lozenges or gums or both, do you think there would have been a difference if, for example, there'd been the inhaler version in the study outcome? That was
good question, actually. In terms of the inhalator, though, unfortunately, it's going to be taken off the market very soon, it's a really good tool that we have, but unfortunately, the resin that's developed it won't be able to be used longer term. But, I mean, you also have the mouth spray as well. But to answer your question, I haven't seen a direct comparator that looks at directly mouth spray, even with actually nicotine patch as well, which would probably be the best in terms of combination. But in terms of the current evidence, though, the best that I've seen in terms of the comparing a patch with even gum or lozenge or other, well actually, sorry, I backtracked there because there is a UK trial that I'm pretty sure allowed for the participant to select another form of fast-acting NRT. So that trial actually showed a 9% and 18% quit rate in the vaping group, and the superior effect was found in the vaping group. And then also that trial only used 12 milligrams per mil, one flavour, and it had used obsolete, the free-base e-liquids that I'd mentioned earlier. So, I mean, that's a guide for us in terms of sort of a direct comparator, but I'd have to look a bit closer at the data to see how many actually used the mouth spray in particular in that trial.
Brilliant. Can I ask, were you surprised at the size of the intervention effect? Was that near your sample size calculation?
Good question, Matt. When you start a trial, when I write a grant proposal, it scares the living daylight out of me. I've got to get this estimate right because I don't want to spend all this money and find out I'm underpowered. So at the time point, to be fair, it was a bit of a stab in the dark because we only knew at that time point there was only 4 or 5 probably RCTs in the Cochrane review they'd all used freebase at that time point. We'd been funded, and nicotine pods sort of just started to come up on the horizon. But I think we had 8 and 14% as our best guesstimate based on the literature. And the products far exceeded that. The nicotine pods were a really good delivery system. People really liked the alt pod in particular. And the fact that we'd provided 4% or 40 milligrams per mil, I think did allow for an ample delivery of nicotine. I'm not sure whether or not a dose at 20 milligrams per mil for that product would matter, because I think people will still change the way that they vape. But to answer your question, yes, that was probably the most significant effect our statistician has ever seen. Like, it was amazing. You couldn't wish for anything better as a researcher, I'll tell you. Yeah.
Brilliant. And it'll change practice.
Yeah.
And shut up those public health people who moan about vapes, I hope. Of which none of them are here. Good. So thank you very much, Ryan. It was brilliant. So I hope you agree it's been a fantastic day for science, fantastic day illustrating lots of amazing studies. Now, so we're going to have a little closing reflections from Michael Farrell, and I've got 3 paragraphs on Michael, and I'm not going to go through it because I think you've seen him before. You know who he is. He's lost his tie. Okay, over to you, Michael.
Thank you very much. Okay. I'm aware it's been a long day, and it's that time of the day where people are beginning to flag. I'm talking because this will be my last symposium, and I want to thank everybody today for the absolutely fantastic range of work that we've seen, which is a credit to the whole of Australian researchers. So what I was going to do was look back to bookend where we started this morning with the discussion with Norman Swan, where we heard very interesting reflections on what had happened. And I'm going to bring us through that again from the point of view of NDARC. And first of all, I just, again, like to thank all our funders, all our stakeholders, people with lived and living experience, and all of the researchers across, and all of the clinicians and policymakers. So NDARC was established in 1986, which is just under 40 years ago. And the whole research initiative was the outcome of a special Premier's Conference on Drugs, which was related, as we've heard this morning, to do with the rising use of heroin and crime. But it also came from a previous Senate committee thing, which had a recommendation on called Australian Intoxicated Society. And it recognised that there was very little research on alcohol and other drugs. Now, I have to say, as I sit here, I particularly feel I have to mention Alex Wodak there. Because, and many others, but Alex was one of the great champions of all of this. And thank you, Alex. So, what has happened then over the 40 years, and what does the future hold? That's the sort of question. There's a paper I read in preparation for this, which was by Blewett on the establishment of the strategy, and he looked at it 20 years ago, 21 years on, and he reflected on what had happened in 1985. And I think there are a few lessons for us to learn from that. What they said in that one was that at the time when that meeting was being convened, that the health people, particularly the health bureaucrats and the health policy people, were aligned they went in with a very clear aim, and they probably outperformed the criminal justice people, etc., at that time. But they also were very clear that while the problem was heroin that people were worried about, they made a very clear message that tobacco and alcohol was also a huge problem, and that you shouldn't forget those when you're dealing with your current and immediate problem. And that's where the strategy came in. But also, there was a passion around establishing harm minimization. And that was, at that point in time, people may not realize now, but it was a paradigmatic shift. It was to actually be clear, we are not just about stopping people using drugs. Our role is to ensure that if people use drugs, they affect the least amount of harm possible. And at the time, that really was a whole shift of thinking. And they also called for the building of the evidence base. And that's where NDARC came in. And I think there's another person I'd like to mention who has been at many of these meetings but isn't here today, which is Professor Ian Webster, who was the acting initial director and has been a long-term strong supporter of us. So I think, but also to mention the first director of NDARC was Professor Nick Heather, who passed away this year. So I think it's important to recognize, the founding director. And I think also to note that at that time, one of the things Nick was very passionate about was controlled drinking versus abstinence. And there was great energy around this whole issue, which at the time was the preoccupying debate probably between some of the leaders in the field. And what that brought at the time was motivational interviewing, relapse prevention, a lot of the psychosocial approaches to, specifically around alcohol and smoking, were generated at that time. But I mention this too because of that book there. And I think, Alex, you're probably one of the authors in that book. But that book I came across when I came to my first harm reduction meeting in Melbourne in 1992. And that was a very important meeting, again, around international collaboration. Because a lot of people in the UK, in Australia, in Europe, recognized that we had a big challenge to stop HIV, and that the terms, and a lot of that book was around defining what harm reduction was, having complex discussions around it, but also building a coalition of people that were supporting this type of shift. And I know Alex was involved in particular things around the fight for needle exchange and a lot of these things. But the thing would be, the other thing about Nick would be in establishing NDARC, there was also, at that time, he did quite a bit of work around, they actually had a experimental bar in the place where they did studies. Now, we probably need another experimental bar. And they did smoking research, and they developed a very broad program of research. And then Nick left in '94, and this chap took over. He had been the deputy director, Wayne Hall, and he did a lot of work around cannabis dependence, but also a link in with Richard Maddock to a lot of work to build up the evidence base around methadone treatment and making the case for the science and evidence for methadone treatment. And that resulted, both Richard, myself, and a chap called Jeff Ward produced a book on the methadone maintenance treatment. And this was internationally very influential. We use it a lot in England to make the case. And Richard was director from 2001 to 2009. And along there, so the point of this is from the NICS, the 1992 conference in Melbourne, we agreed together, and I don't know if Shane Dark is here today, but he was here. I think he may be gone now, but Shane was pretty critical to the studies of overdose, but also this was the first editorial calling for take-home naloxone distribution. And the other thing we did, following on from the methadone book, we wrote a BMJ review with the key aim, of further promoting broad provision of methadone treatment. And I didn't realize that I was on a slippery slope to Australia at this stage. So that by 2011, I'd been trapped. So, and I've just put those up as evidence of some productivity sort of thing. So what, in a sense, if you look over the period of time, what have been the achievements of NDARC? And it's not just NDARC, I think it's the whole field, and I'm very important to emphasize that, but I am talking about it from an NDARC perspective today. And it really has been building the evidence base across the substances. And I think work like the development of drug trends has been really important to develop an information framework beyond the household surveys to understanding the fact that there was groups that we needed to zone in on differently. And that has gone on now for nearly 30 years. On top of that, there's been the national and more laterally with a lot of Louisa Degenhardt's work, the global epidemiological studies, providing very clear data on global treatment coverage. And that I know a lot of us collaboratively have been over many years involved in international organizations and national settings promoting the use of treatments that a lot of health professionals were basically resistant to. And that has been really important to develop that framework. And that has gone along with developing a program of systematic reviews. And on top of that, you've heard today about clinical trials around tobacco, alcohol, opiates, and stimulants. And on top of that has been the work. We've really developed a systemic infrastructure of work around data linkage studies, and that's taken quite a lot of investment. And all of those come and contribute to shaping national policies. And also there's both partnership with key researchers and supporting Nadine Ezard to get NCRED going, and the partnership with both NCRED and Vincent's and clinical networks. We can always do better on that, and we should do better on that. In that time, 108 PhD students have completed. And they've gone into mental health, public health, higher education, and government policy. So you create a knowledge framework, not just in data, but in experts who can go into the field and do things. And the publications stand for themselves, but both grants and publications, some people may be a bit dismissive of them, but they are important as evidence of productivity, and they have far-reaching communication in terms of the quality and the high quality of the work done. So if we look at it, we have to build strategic national and international research alliances to build the strengths. Having Steve Shoptaw here today talking, and Matt Hickman, we really need international alliances to build and do the best possible work, nail the questions, and really, and I think the other thing, if we listen to Ryan's presentation, what we hear is new methodologies. We're talking about randomized trials that are community-based, attracting people, large cohorts from the community over a short period of time to come up with really important evidence. And I think really, I will say this with caution, that I don't think we need to think that everything will go smoothly. I think there's a lot of bumps on the road. There's a lot of bumps on the road internationally at the moment. There's evidence that things can slip back. And that's why having the evidence and continuing to advocate is critically important. And one of the things we really have not made great progress on is tackling stigma and discrimination. We're really still back at the very beginning. So we have to develop and strengthen the alliances with people with lived and living experience to generate key research priorities and enhance opportunities for co-design. In terms of what we're doing in NDARC, we have our research strengths around, I'm having trouble reading from this distance. I better turn around. From both the epidemiology, prevention, treatment, harm reduction, and mental and physical comorbidities, drug policy, criminal justice system, big data, and priority populations. I have to call out for Don Weatherburn here in relation to the importance of doing research that looks across between the criminal justice system and the health system and how we get that to work better. This is work that Louisa Degenhardt has done for a long while, and it's very simple stuff, isn't it, Louisa? You just press a button on the computer and the answer comes out. That's what she tells me. But again, it shows that tobacco has a bigger burden of disease than alcohol or illicit drugs, so that actually it reminds us when we're looking at things from an integrated point of view that we have to keep that in mind. And I'm just going to, I have time, so I'll just go through it. You've heard a lot of this today already, so I'm going to zip through it and save you so that you can get out and talk together. But just to see, the Analyx was part of the clinical trial for the first methadone randomized control trial in prison. We've done buprenorphine studies looking at global coverage, and in particular, the program with Jason and Greg Dorr on the Ascend and global hepatitis C was really important, and looking at national and global clinical guidelines. And then at the bottom there are the important linkage studies with Alice Havard and Louisa and a lot of the team. And the Transform one is a National Institute of Health study across things. So there's a lot of work, and there's this range of linkage studies. Looking at this thing in terms of, I think that 2 or 3 things that are important for us to look and appreciate around some of the linkage work. One of them is the work done to show that the opiate dependence treatment in New South Wales has reduced mortality by 40% over the last decade. And that's absolutely remarkable by comparison to other countries in the world. So, and the retention has gone up, and this is, again, evidence. The thing about the opiate work now, I think, is we are arriving at the stage where the robustness of the findings are getting nearly incontrovertible. And again, the issue being that despite that, the overall availability remains restricted, and the push to promote that, but also the problem about that not happening. And this is just showing work that I've been very committed to over a long period of time, showing initially we showed that the mortality rate on the first month from release from prison was 70 times higher for the first month, and that actually that treatment that continued from prison out could reduce it by nearly 80%. And yet that is not, if we take the United States, it's hardly implemented. There's a few small studies. In Matthew Hickman with me, we did a big study in the UK, and that moved forward, but I think it's fallen back, hasn't it, Matt? Yeah. And now this is just, again, Don Weatherburn doing work on the magistrate's early referral into treatment and showing the significant reduction in reincarceration in those who referred and completed treatment. So the need for substantial expansion in diversion treatment remains pressing. Now, you've heard quite a bit this afternoon on Rebecca's TINA trial, but again, the work on methamphetamine is important. I'll go through this quickly. And then the other bit has been contingency management. And the fascinating thing about contingency management is that it's one of the few things that we have evidence works and one of the few things we cannot implement. So make sense of that. And the interesting thing about the research Rebecca is doing is not to ask whether contingency management works, but ask is how do we implement it? And that's where looking at novel methods to do that. Now, just to finish with the tobacco research group, Ryan has presented one study, but he's actually done a whole range of studies. He's done initially this cessate study, which was taking a drug, cytosine, that had been reported for use in Eastern Europe, and did a randomized controlled trial, non-inferiority study, and he just about missed finding significance, but found that it's a very cheap and usable drug for tobacco cessation, and we're hoping that we might be able to see it come into use in Australia. He's also done the vaping study, break the habit study, and quit by phone. I'll just jump over those. And the other thing is the stuff we heard from Amy Peacock this morning about alcohol, and Amy's also now got an MRFF funding to do a youth cohort study, and we're also doing work on cannabis. And then Sarah Farnbach has been with her team, with Peter Gates, been doing work on community prevention, rural and regional work, and evidence for so. And just to mention at the end, Louisa with me and a lot of international people looked at the Lancet Global Commission on Gambling, and one of the interesting things in that is the issue of gaming, gambling, and other behavioral addictions that we haven't really got our teeth into very much. So to finish up, I'd like to thank people. I'd like to thank all the staff of NDARC, amazing people. And I'd also like to thank the funders. I'm doing this twice because I want to make sure I don't forget anybody, basically. And so, looking to the future, I think the future is bright. But the challenge for us is, I think, that we haven't done enough to reduce the suffering. We haven't convinced people to really invest in making the tools available for people to help and cure people and that if it was another condition like the cardiovascular or the other things, the cancer, we would have had a lot more invested in ensuring. So I do think we continue to be in a field that has been, it isn't just users who are stigmatized. I think the entire field is stigmatized in terms of both investment and support. And I think we have to keep on working on that, and we have to do it as an international collaboration. And I think, just to finish up, one of the challenges for us at the moment is we are living in an environment where people like Mr. Trump are actually anti-globalists. And we are committed globalists. We're committed to working across the world to support each other. So I think we need to work closely. We need to band together and fight the anti-globalists. So thank you very much. Sorry if that was a bit of a rant, but now I'd like to thank everybody for coming today, both in person and people online. People online have had a long day, I think. I also have the honor and pleasure of announcing the poster winners. And the poster for the Judging Panel Award, the winner is Agatha Christineau. I don't have anything to give you, so. And the People's Choice Award is Lucy Tran. The winners will receive $500 in research support funds and a $100 gift voucher, but not from me at the moment. Recordings of all the sessions from today's event will be available on the NDARC website shortly. And I'd really appreciate if you could complete the feedback survey via the link or the QR code. It's very helpful for us for future planning. And I'd now like us for all of you to join us in the foyer for refreshments and networking. So thanks very much.